And today I'd like to talk to you about mastering the posterior capsule, thinking out of the bag. And that would be truly a paradigm shift, I think all would agree. And I do have some consultations which are, the menosis is relevant to this as I pursued them for the purpose of it. Now, blood aqueous barrier breakdown and healing response we're all aware of, and of course we're very aware that there are two branches to that, proliferation and transformation, and the one leads to Elschnick's pearls, which we know causes PCO, and the other, which we don't really think about this process quite as much usually, is the fibroblastic and myoblastic transformation that occurs, causing opacities and rigidity, and particularly phimosis, as well as wrinkles and contraction. And we're kind of accepting of that as a routine kind of a thing that happens to us. And it is when the lens epithelial cells actually touch the lens material that causes that transformation to occur. And there have been so many efforts, of course, to block LECs, even efforts to kill them, you know, with a Maloof ring, the Maloof perfect pupil that tried to poison the cells with water, and none of it's really worked, which is lucky that we don't kill them all, because there's some evidence that they participate actually in the process of keeping the bag and the zonular network healthy over time. But of course we have truncated optic edges, despite the fact that we accept more dysphotopsia because of it. We want to overlap that anterior CCC, which is one of the few drivers for femtolaser and really has not necessarily proven to make a difference in refraction at this time. Sharp-edged optic junctions and sandwich effect we know takes place, so there's sort of a dichotomy between trying to polish all of the cells on the anterior capsule, which we know actually increases our PCO rate because of loss of sandwich effect, but it decreases our transformation and fibrosis and phimosis. So there's kind of a tension between those, which is better for the patient. And capsular bending rings have never become FDA approved, but when you separate the capsules, it may help. And filling that capsular bag, we've never really accomplished with a lens that's gotten anywhere, but that seems to help as well. And of course, in the pediatric field, where there's 100% PCO after cataract surgery, the standard of care is routine pediatric anterior vitrectomy and vitrectorexis, which we would consider a complication in adults. And this barrier effect is lost despite all of our attempts up to 38% of the time. And there are many different studies to show that rate, and some may say less, but some people don't follow their patients for 5 years and may not be able to capture all that data. So this is kind of a little older picture, but the routine thing that we see from anything that we accept as normal to something that can be a problem and leads to some of the epidemic of bag lens subluxation. And there's no question, however, that phimosis, as long as there's a nice opening and the lens is stable, we consider that to be fine. Or when we get fibrosis all over the place or PCO everywhere and we make that nice little central YAG opening, we say now the patient sees perfectly. But there's good evidence that even a clear 20/20 Snellen capsule causes stray light problems, as well as the fact that that fibrosis does cause decrease in contrast sensitivity. And we accept this as normal, but you can't really do a YAG laser, or virtually never will you do one and leave the hyaloid intact, which has been proven to be the final protector of the two-chambered eye. And CME and so on are consequences. You know, it's routine. We love playing the video game of YAG. We get paid really well for it. Nevertheless, it leaves floaters. It blows the anterior hyaloid, and all that fibrosis all around is really, or Elschnick's pearls, is really not perfect vision. So what can we do about that? And we've just accepted, you know, it is called a complication, secondary cataract, and it is the most common complication of cataract surgery. So the second line of defense is to do a planned posterior capsulotomy or capsulorhexis, and I'd like to talk to you a little bit about that because it's part way to where I believe we need to go. And in the adult, it doesn't decrease PCO to 0, but rather something like 2 to 5%, which is still highly valuable compared to 40%. And in pediatrics, it's not not good enough because the stable foreign vitreous can allow a scaffold on the anterior hyaloid itself, and very often PCO progresses. So reasons to master a PCCC alone. There are many reasons without your having to change your practice pattern. Just get better at what you do, because it's not only important to reduce PCO, but it's important to convert, to have that technique to be able to convert an unstable accidental rent in the PC into something stable for bag implantation, to allow immediate rehabilitation. You know, we'll leave an unpolishable plaque behind, patients 20/40, not so happy. We wait for the blood retinal barrier to come back, you know, the BAB to restore, or till you can pay again out of the global period, you know, and then we do a YAG, but they don't see right away, and there's no reason to leave it that way. Also, I might add, for the posterior polar cataract that has a very thin and unstable central posterior capsule, it's so easy to break that when you apply any force or allow any change in your chamber, even after you've removed the cataract and the capsular adhesions of the lens. So if you do a primary posterior capsulotomy, now you have a nice stable situation. And then when general anesthesia is needed and a patient can't sit for a YAG, don't you do them a favor to not have to have another general anesthesia to learn it. So here's an example, and I'll let it talk. Can you hear it? So I'm going to let these voiceovers speak for themselves where they exist. Here is an example of a very mature cataract with an unpolishable plaque, and I have an hour lecture on brunescent cataract if you ever wish to hear it. I gave a little bit of that yesterday to the residents, but here we're going to manage this with something I've described that's in the Phaco-Chop textbook that David Chang has edited, called Circumferential Disassembly, and I won't show you that whole thing, needless to say, but here we finish the last bit nicely, and despite all of our very meticulous removal of any residual cortex and careful polishing, we have a significant plaque. Now, it's important, of course, that you don't have fibrosis that goes beyond where you can afford to take capsule, or you have to cut across that, and it's not quite as strong, because when we want to make a PCCC and it's a very lax bag, it's very helpful to place a CTR first to make it nice and stable. Naturally, if we have a hole in the PCC, in the capsule, either capsule, or a tear, we can't put, it's contraindicated to put a capsular tension ring, but once it's in place, and this is just to show you, get the bubbles out of your thing first. You want to use a 30 gauge needle, and you'll see a better example of this, to make a little hole. And then, because Berger's space is sometimes potential and not totally formed, we form Berger's burger space with OVD. Cohesive OVD through the little hole that's made with a bevel-up needle is helpful, and you'll see another example of this in a moment. A more pure example will allow us then to push the hyaloid away so that we can separate it from the bag entirely, and we can do posterior capsulorhexis. Now, in this particular case, because there was so much fibrosis, I did not choose to optic capture because I didn't want to stress the edges because of the fibrosis, but nevertheless, we have very safely protected the hyaloid, and we're able to remove this plaque that probably would have been a 20/50, 20/60 plaque, and compared to the hand motion vision the patient had before, he might have been pretty happy. But on the other hand, if we plan to do his 20/60 eye, in a week, we don't want to have to wait 3 months to get full visual recovery, and there are complications with YAG lasers. And at that point, he could still be having his vitreous detach, and then there's a higher risk in early YAG for RD and for retinal tears and detachment. Not to mention, if you mistake the fact that there's still some inflammation, you have a higher rate of CME, and that's all because we break the hyaloid when we do a YAG laser capsulotomy. So now we're going to put our OVD into the sulcus of the bag to blow the bag open. We have kind of a spare tire with an opening in the front and an opening in the back, and we're going to go ahead and place the lens in the bag, a one-piece lens, and this patient can be 20/20 the very next morning. And given my technique of brunescent lenses, it's hard most often to tell a brunescent cataract from a standard one the next morning. Now, burger space, the vitreous is a complex organ that we now understand because of the work of Jan Worst, and burger space really does exist. And Marie Tassignon, Marie-José in Brussels has discovered that maybe 1% of posterior congenital cataracts may actually have an anomaly where there is no burger space, where the anterior hyaloid's actually attached, probably a form fruste of PHPV, but by and large that space exists, and it may be potential or it may be real, and you can actually see it. It's delimited, of course, by Weigert's ligament and the posterior zonules, and it's between the posterior capsule and the anterior hyaloid. And you can see it in this particular case post-op. Now, this is a typical case of mine, and it's a little bit lengthy at 4 minutes. I think we have time for it still, even though we started a little late, and it's important. I'm just showing that it's very important to make sure that you make the proper size anterior capsulorhexis, because this is your backup. This is what you're going to use in case you have a complication, and I would never start a posterior capsulorhexis without knowing that I have a perfect anterior rhexis that is smaller than the optic, ideally a 0.5 millimeter or so smaller, or a 0.5 millimeter to 1 millimeter smaller than the optic. So here's our 30 gauge bevel up needle, and that's because you want to skim that little 5 micron capsule off of the potential hyaloid right behind it, and not use a cystotome that might break down into the hyaloid as well. And then you can see that OVD kind of form this bubble, and I'll be showing you another example of this. This bubble is delimited basically by Weigert's ligament, and you have to be a little gentle about placing that. Howard Gimbel, that described this technique in 1994 or 6, he's checking to tell me just when he first presented it. It was published in 96. Actually preferred Helon GV for this, a really viscous placeholder, cohesive. But Menapace, who's done thousands of these as a routine procedure for adults, says any cohesive will do, your Helon, your ProVisc, whatever you've got. And you just need to finish outside of where you began, and you need to have your microscope on high power, because if you need good visualization. Keep in mind this is a more elastic and fragile 5 micron thick membrane, but it's not rocket science. We know how to do an anterior capsulorhexis, and this is really just the same with perhaps a tad more centripetal force. Doesn't necessarily go where you like, and people can get, Menapace says it's about 150 learning curve. I made it up to about 100 between the pediatric cases that I did before I retired from patient care, which I have done, and so I'm a little more cautious, but there are people who will do it with just 3 grasps once you get comfortable, and the idea is to make it concentric with the anterior rhexis. Now, once again, we are placing the OVD, cohesive OVD, into the fornix of the bag to now blow the bag open for classic posterior buttonhole, as Menapace calls it, and for posterior optic capture, as Gimbel described it. And I'm choosing a 3-piece lens, though a 1-piece lens can be used. A 3-piece lens is nice because if there's a complication, we have a back door of forward optic capturing, which I'll show you through the anterior rexus, or using it in the sulcus and optic capturing. And it has a lesser optic haptic junction exposure for lens epithelial cells. So if you use a 1-piece lens, it is very capturable. However, it has a broader area at the optic haptic junction where it touches lens epithelial cells, so might excite a little bit more lens epithelial cell transformation. So we're pushing on the pole 90 degrees away from the optic haptic junction, and you need to be a little more thorough about it. With the anterior capture that you're familiar, just one pole, it'll kind of pop down, but because this capsule is so much more fragile, sometimes we have to go all the way on the edge to be sure it's completely over it in order to get that nice cat eye appearance that you see right here of the posterior capsule. And here's the anterior capsular rexus, which of course is undisturbed by and nice and round. And here is our posterior capsular rexus with the cat eye appearance from optic haptic junction to optic haptic junction. And now once it's captured, the hyaloid is totally protected, so we don't have to worry as much as when we just put the lens in the bag about the hyaloid prolapsing around the lens, because it's hermetically sealed, and we can aggressively remove the anterior chamber OVD. Any anterior chamber, any OVD left in the posterior chamber behind the lens will not cause a pressure rise, well proven peer-reviewed literature, due to the fact that it doesn't have immediate access to the trabecular meshwork, and it will slowly go away. So this looks a little asymmetric only because I put in Myocol and the video didn't wait for the whole thing to contract, but the lens is perfectly centered, stable, and it will stay that way for the life of the patient. So will the visual axis stay clear. So here's a beautiful video with intraoperative OCT that Marie-José gave me, this you can see when she comes with the needle here, how she makes this nice little flap, and you can see it over here, the needle making the flap, and you can see that there's a Berger space that isn't completely formed. Okay, this is the posterior capsule right here and the anterior hyaloid, and so you'll be able to see how when she manipulates, it is separate. You can see that separation between it. Now she's putting the OVD in, and you'll see how that completely separates the anterior hyaloid from the posterior capsule and flattens it out. A very beautiful view. And of course you want your cornea to be nice and clear. You want your microscope on high view. You know, you don't want people squirting while you're doing this. I like to coat the cornea during all my cases with a little visco. I have no financial interest, but anyway, dispersive viscoelastic, a couple of drops of water, and that's the last anyone has to squirt for me because the cornea stays clear. And you see she's very practiced at this. She's done, I'm sure, thousands of cases by now because she started very, very early and has designed a lens that I'll talk to you about in a moment called Bag and the Lens. And you can see as she gets that to be just about the perfect size of the anterior rexus, how now we have the missing posterior capsule, and isn't that beautiful? Okay? So it gives you a very nice mind's eye view of exactly what's going on. So what we're looking for in the postoperative period, as I showed you before, is this nice round capsular rexus, and then this posterior capsule, which is from optic haptic junction to optic haptic junction. I jumped the gun a little. There are myriad safety studies. Menapace has done an amazing job of fellow eye studies of no PCC, no posterior capsular rexus standard procedure, you know, versus capsular rexus, of optic capture versus PCC without optic capture, and it is extremely safe in his hands. He had one vitreous prolapse in 150 cases. I had one vitreous prolapse, but it was in a child with an intumescent cataract, and who knows what that cataract looked like before, and it was no big deal because I did a little anterior vitrectomy, you know, which is what would have been standard anyway, and the patient turned out extremely well. Not that losing vitreous, you know, I mean, you have to treat it so that you don't lose vitreous and let it travel. You want to always discover this, so you'll be using some triescence, especially early on, to be sure. Now, here's an example of one case where I actually broke, and I'm going to move it ahead a little bit in the interest of time, or maybe not. Can you hear all right? Yes? Could be a little louder, right? Could it be a little louder, please?
If you adjust the volume on the computer like you're wearing headphones.
Okay, so the point is, because it's hard for you to hear this, the point is, here is the crux of the matter. I chickened out a bit, and I made that posterior capsular rexus a little small. And this is a very, I'm afraid it'll stop it if I start messing with this here. Okay, that's great. So you can see here, I'm forcing it a bit, and it's a lens I've never used before, a Hoya lens, and I tried that because it's the one, it was supposed to be the one Manapachi uses, but it turns out that one was not FDA approved. At any rate, I recognized that I broke that posterior capsular rexus. And so what I'm doing now is I'm cantilevering it forward in front of the anterior rexus. So you see, we always have a back door as long as you make a good anterior capsular rexus. So in this case, although the posterior capsular rexus broke early in my learning curve with this particular lens, I was able to pull it forward and proved with triessence that there was no vitreous prolapse, and actually the anterior hyaloid remained intact. It was just that the edge of my posterior capsular rexus broke. So now it's no longer absolutely secure to leave it in the bag, which is why I forward captured it. And you'll be able to see that there's no vitreous forward, and using triessence, of course, on label for particulate identification of vitreous is very important, especially early on in your learning curve, or if there's anything that goes awry in any way, shape, or form. And this patient did beautifully with no problems. Now, I want to talk to you briefly about a lens that is not FDA approved. Whether or not it ever will be is debatable, and this was designed by Marie Tassignon. And instead of putting your lens in the bag, with the haptics in the bag, she has a lens designed with a collar button 360, no actual haptics. And you fit the anterior and posterior capsule leaves into that collar button. This is probably what made Masket, do his little groove, think of that little groove, but it has no haptics. So it is completely dependent for centration, which has been an issue, and now she has all sorts of devices to keep it centered completely on the capsular rexes, being the right size and the right centration, and totally on zonules holding the bag in place. But if you look at the Kaplan-Meier curve for PCC, you can see that in the bag and the lens, of course, we go down and it ends up about 50, in this case, 40% or so. And in almost every case, if you wait long enough and use all our modern techniques, and it's 0 for these. And you'll see here that, in fact, in all these patients, not accepting diabetics and glaucoma patients and babies and lens exchanges and all sorts of stuff, 0 PCO closure rate. Okay? And more importantly, because the lens, there's no lens material touching the lens epithelial cells, here's what a bag in the lens looks like on the capsule. Afterwards, you can see the cellular proliferation and the transformation that's occurring. And here's a bag in the lens capsule. Okay? No cells to cause phimosis and opacity and rigidity. Now, that's what it looks like. And these are babies. These are adults and babies, and this is what it looks like, equator to equator clear. And it's interesting that she was shocked to find when, and I ended up going to Utah to Liliana Warner's lab, that there is sometimes some Summering's ring in the periphery, particularly in children. But it was she was totally unaware of it clinically. It's confined to the equator because the bag gets sealed to itself, and this stuff is out there, but no transformation. So you see that beautiful clear view. I'm going to get done on time. Neither is ideal, though, in my opinion. Posterior optic buttonhole, okay, a posterior buttonhole technique is still zonule dependent, even though if we vigorously polish the anterior capsules, because now we're no longer needing a sandwich effect, we're going to have less phimosis, and that might do. But it still leaves us with one other scourge that we have more and more in modern cataract surgery. Not only PCO is the most common thing, but I think we're finding that late bag lens subluxation is becoming more and more common as well. Bag in the lens is totally zonule dependent, so we're still at risk for subluxation, and in fact it happens not infrequently, and she's putting in unusual capsular tension rings to kind of center the thing at times now, and there's no possibility of accommodation either. And I want to step back a moment and talk about bag lens subluxation, which brought me to this, I believe, epiphany that we need to change our technique entirely to something routine routine that has never been recommended routinely before. And that is that I knew that bag lens subluxation was a problem, and about 8 to 10 years ago, I surmised that since every bag lens subluxation has an intact capsulorhexis, you know, we had tons of IOL subluxations prior to capsulorhexis, but they were not bag subluxations, and it's a brand new thing since the development of capsulorhexis to have bag lens subluxation. And although most of them have pseudoexfoliation, not all, although it's interesting that in Liliana's lab they did find that patients that had no clinical history of pseudoexfoliation who had bag lens subluxations that were sent in had subclinical findings of pseudoexfoliative material. So it may be a lot more common than we think. And it's not prevented by a CTR, though. That is a nice idea because then you have 360 access for lassoing it, you know, when you have to go fix it later, and it is becoming epidemic. So I decided, why not?
This is an eye that presents the typical signs of very loose zonules. You can see it's difficult to create the opening in the anterior capsule, and there's a pin-cushion effect with stria that radiate to the periphery. We are managing to get the initial flap cut, and now we're using forceps to guide the rhexis. It's difficult to get the vector to go in the predictable manner. Sometimes these will go more wide than predicted, sometimes more difficult to keep it wide, and they end up small. It is worth our while, however, to keep it always with the proper vector, regrasping whenever necessary. And if it's impossible to pull, and we think the capsule is moving too much, then a second-hand instrument can be helpful, supplying counter pressure. Now, hydrodissection can be a challenge in these cases, and we're looking for the right plane. You saw an initial wave, and yet, even though we're going in multiple directions, it's hard to get this nucleus mobilized. Therefore, we're going to do a multi-directional hydrodissection with J cannulas or big horse cannulas, being careful to take it out the incision without harming desmase. And now that we feel that perhaps we've sufficiently hydrodissected that lens, we're going to begin phaco. A chop technique is desirable. Vertical chop is my goal in all cases. You'll be able to see that there's quite a bit of instability, and here I'm going to very much protect the back bag of the capsule as we finish. You can see the capsule waft around. Now we want to support this chamber, and so I'm putting BSS in through the side port before removing the phaco tip so that we never allow things to collapse. And at this point you'll see how very mobile that bag is, and so we're going to deliver rather than strip the cortex, gently trying to avoid high vacuum and rapid movement so that we can gently remove bit by bit of this cortical material and not disturb the zonules. If we find we cannot do this and we actually see the equator waft into view, then we would place the capsular tension ring early rather than late. If the lens had been less stable, we would have used hooks to stabilize it during the phaco, in fact. Now that we've got the bag clean, we're going to place the capsular tension ring. And because the bag is not decentered, we can lay this ring in place and very slowly, with good proprioception, let it go into the equator. Now I'm checking to be sure that the rhexis is small enough for optic capture, because I've opted now, rather than place a lens in the bag, as is typical of our usual technique, to rather sulcus implant an optic capture, with the theory that this prevents phimosis of the anterior capsulorhexis, since the optic will actually prevent it and tamponade the opening. And we're using a two-handed technique, and this is perhaps even a little extreme how far we've allowed this to go into the sulcus. We've defined the sulcus so that we can easily place the leading haptic, and now we're going to press down on the poles 90 degrees away and take a look and make 90 degrees away from the optic haptic junction, that is, and make sure that we're optic captured. Once we know that we're optic captured, and this has to be, of course, a 3-piece lens, a 1-piece lens should never be in the sulcus.
Okay, so that's the point. So for years I've been doing that, and I want you to know. Here's the. I'll finish it this way.
It's a little little more obvious how the optic capture works, and you can see the poles of the optic going below the capsular rexus. Here's an eye of a pseudoexfoliation patient done in the standard technique, where we used laser soon after surgery, just a month after, and then re-lasered with relaxing incisions after that. This is her fellow eye, in which I put an optic captured sulcus lens, and this is what we're trying to avoid.
So I decided to do that, and I'm, as a high-volume clinician, I didn't have anyone to collect data, and I certainly never did a prospective randomized trial, but there was a paper out of Turkey some years ago, about 2-3 years ago, with 5 years follow-up. We know 8 to 10 years is common, for bag lens subluxation, that showed tremendous stability. And if you do this, you will be amazed at how there's absolutely no pseudophacodenesis. I believe that the bag supports the lens, and the lens supports the bag, and then we keep from having phimosis because of this stenting of the anterior capsular rim, and they are just stable from day one on. So anyone, and unfortunately no one has yet come up with a really good objective assessment of zonular laxity, but I have my own sort of internal idea. If I get the buttonhole, I get the stria on opening the anterior capsule. I can tell that I'm moving the bag a tad when I do my rexus. I need to deliver my, we can't easily hydrodissect and rotate our nucleus without zonular stress. We have to deliver all of those things. I always did this technique for many years, and I was very, very happy with it. And so it occurred to me one day that, and also this is another part of my thinking process, this was a paintball injury, a traumatic injury. You can see the iridodialysis, and there's a traumatic iridoplegia, and it had a pre-existing hole in the posterior capsule, which is what you're seeing here, the fibrotic edge of the posterior capsule. And we got everything cleaned up and had to do an anterior vitrectomy, of course, in this particular case, because that capsule was already open. And I decided, since I couldn't totally depend on the zonules, I wasn't comfortable placing a capsular tension ring, and I certainly couldn't depend on the bag necessarily, that I would optic capture. And it occurred to me, why not optic capture through both that fibrotic opening? And by the way, once there's fibrosis in the posterior capsule, it can be fairly strong for capture, and even Gimbal has examples where you can sew to the bag itself without the bag breaking. So I decided to put this in the sulcus and then optic capture through both the anterior capsular rexus that I had made and through that pre-existing fibrotic opening in order to keep everything stable. And boy, that eye was stable as the day is long and did very beautifully. So it was with these experiences, and it was described by Dubroff somewhere around 2005, the concept of bicapsulotomy capture as a potential thing to do for pediatrics, but never really followed up on, and I discovered that long after I came to this concept that we could bicapsulotomy capture, and that's what I want to talk to you about next. So you can see, and this of course goes on to fix the iridodialysis and so on and so forth, but you can see how nicely centered and stable this is, despite the fact that we have 2 out of 3 breaks, okay? But we had a perfect anterior capsular rexus and a small zonular loss, which isn't a progressive zonulopathy like pseudoexfoliation. Trauma, of course, is a defined zonulopathy, so unless you unzip zonules further with your forces, it's going to stay stable. Now, so introducing sulcus bicapsulotomy capture as a routine procedure. I like to call this SBCC, which I don't think anyone has coined that term, and I've written about it in iWorld, and I plan to follow this further. I'm hoping to do some rabbit studies to show its advantages, but I believe, so it involves making the anterior capsular rexus as smaller than the optic. Otherwise, I wouldn't even attempt to do a posterior capsulotomy because you wouldn't have a healthy back door to take care of that patient's eye. Removing the bag contents as usual, polishing that posterior capsule. I really don't think you have to vacuum. You have to be thorough about removing your cortex, because the more you leave, the more Summering's ring you invite. However, once you get your posterior capsular rexus done, then you put the lens in the sulcus and you capture through both the anterior and posterior capsules into Berger space, giving us the effect of the bag and the lens, but stabilized in the sulcus. Now, there is no sulcus approved FDA, no no FDA-approved sulcus lens. You may think so because they call it that. The lenses that we have today, are too short for most sulcuses and really need to be optic captured to stay stable. And I believe that sulcus implantation got its bad name first because there were huge rigid implants that were in there that actually eroded through the ciliary body, and then second because we put a lens that doesn't fit if we don't optic capture it, and it can subtly move and cause UGG and cause other issues. So I believe if we I certainly with those optic captures in the pseudoexfoliation patients, the anterior capsule, I've never seen any complication of UGG or transillumination defects, and I think it's pretty well accepted that we can anterior capture. So ergo, still perhaps some rabbit studies are appropriate. So this is just to depict, this is the standard bag posterior optic capture with the haptics in the bag, and then the optic below both anterior and posterior capsule in Berger space. And here's what I'm suggesting, the lens in the sulcus, and then bicapsulotomy capture, which will seal things hermetically, allowing the two capsules to seal together just like the bag and the lens, but not be dependent entirely on zonules. Now, my good friend and wonderful surgeon, Kathy McCabe, has done this, and I don't think you really need to hear this, so I'll just explain. And she went ahead, and this was actually her first posterior capsulorhexis as well. And you can see that it's not that hard to do, to place this in the sulcus and then capture through both ends. She made the posterior capsule a little bit smaller than it needs to be, but nevertheless was successful in bicapsulotomy capture. And then after this, I'll be able, we're doing okay on time, I think. So you'll see that, a little bit of manipulation. This is her first and only case at the present time. And this patient has done very well. I was sort of hopeful that she'd be able to look for a possible accommodation in that if we have Weigert's ligament intact and we have our anterior hyaloid intact and we're sulcus based and we have a flexible capsule, at least Dan Goldberg believes it's plausible, and he is the world's expert right now on accommodation. At least many people recognize him as such. He believes it may be possible, especially if we design the lens for that. But any FDA-approved three-piece lens can be used for this particular process. And here it was perfectly stable. She had chosen someone with a 20/50 macular degeneration to do this on, so there was really no accommodative effect that she could elicit, but it remains to be seen. And we're on the leading edge. I gave this talk for the first time at my alma mater at University of Iowa, the Wolf Lecture, and Tom Oding, head of the department, the cataract department and the residency program there, decided to use it for an 8-year-old JRA patient who was monocular because of all kinds of problems of phimosis and posterior capsular opacity and YAG lasers and the uveitis that went with that on the first eye. And so far at 6 months, she is pristine, as are all the pediatric cases that I've done over the years, and all of the patients. I've never seen the lens subluxate, move in any way, or have posterior capsular opacity develop. And the eyes are very, very quiet. And that's, I believe, because you've sealed the antigenic material that's left behind inside the bag without it constantly being able to leak out into the milieu and affect the immune system. So here is his video. It should start.
Described this wonderful technique when you want to stabilize a lens in a young person, and you also want to prevent posterior capsular opacity. She described this recently when she gave the Wolf Lecture here at the University of Iowa, where we're proud to say Lisa was also a resident. First, we're doing this anterior capsulotomy on this young 8-year-old girl who had a history of severe uveitis and was monocular. You can see how it's a very elastic capsule. You have to keep pushing in as you do the rhexis with a lot of shearing force in order to stop the rhexis from going out. And we're trying to make rhexis here, which is around 5.5 millimeters or so. We have 6 of those because we're replacing the MA50 lens. And we want this to be just smaller than the Optic. So the anterior capsulotomy goes well. It's nicely centered. Now this lens was soft in this young girl, and the actual removal of the lens was trivial. And after we remove the nuclear material, the working material, we place a 13 millimeter capsule retention ring. This is a preloaded capsular tension ring, which works nicely in the situation because we want to prevent phimosis. We're going to use a 27
I don't think you need that, only if the capsule's lax.
with cohesive viscoelastic to push back the anterior face of the hyaloid. And this, again, was prescribed to us by Dr. Arbisser. And we're going to...
It's not my technique, it's Gimbel's.
...have this posterior capsular rent sort of move toward us a little bit. You really have to use shearing forces on this very, very thin posterior capsule. We want this to be around 5.5 millimeters or so we can later capture the optic.
5 is plenty, because it's quite flexible, it's quite elastic.
A lot of pulling in forces here to sort of shear it to stop it from going out. And this goes really nicely. You can see that the posterior capsular opening is just a tad smaller than the anterior capsular opening. Now we're going to place an MA50 lens, and we're placing these.
And I don't think you need a 50 either. But that's why he's making a bigger rexus, because it's a 6.5 millimeter optic.
Dispersive viscoelastic. So we have some space to place these haptics. And now we're pushing this optic posteriorly so that it's captured both by the anterior capsule and the posterior capsule. And this is the interesting thing that Dr. Arbisser taught us, is we've got the anterior hyaloid intact. We've got this lens capture, we've got a capsular tension ring in the bag. And so it's hard to imagine we can have phimosis long-term in this patient, and it's hard to imagine we can have posterior capsular. This is Tom Odie, University of Iowa. Thank you very much.
So, what's holding this up since 1996? I mean, at least regular buttonhole technique, you know. And I went to Vienna actually to learn the technique from Menappachi because he was doing it routinely and was the most published in the literature about it. And the learning curve is a little bit scary, you know, because you've done your perfect case now. You throw your lens in and you're out, right? But instead, you're going to start perhaps the hardest part of it, but the most worthwhile, actually. And so how to make this accessible to the average anterior segment surgeon? And so I want to talk to you first about the fact that it's extremely accessible today, and actually the only real reason I can think of for certain for having a femto laser is to have it in your OR and be able to redock for some difficult cases, and particularly to be able to do a PCCC, which it can do. And it's interesting that Burkhart Dick has published, and I got a femto before I retired mainly to study this, although the FDA decided to change its language of art and change the from no indication under age 22 to contraindicated under age 22, even though there's no evidence that it's bad. But they say, oh, well, we don't mean the usual medical contraindicated, but just imagine for your IRB, you know, for being in court and it says, well, doctor, it says here it's contraindicated for underage. On the contrary, it's most important for under age 22. So that's kind of an issue. Also, in the United States, people keep their, keep their femtos in a separate room for their ergonomics of going room to room, which probably is not such a great idea since we know prostaglandins are released the moment that we open that capsule, and the longer you have in transit, the more inflamed that eye is going to be, and the more meiosis and so on, and more you need omidria and so on to take care of it. Nevertheless, Burkhart Dick, who has it in his OR, has done these, and when I saw him do it, that's when I wanted a femto. And in 72% of adults who've had regular flax, either because fluid goes around the zonules or just that's the way they are, the catalyst laser is able to visualize the posterior capsule. And here it is. It's off-label. You have to jigger around your settings because there's no algorithm for it. But here he's placing, in the beginning he was placing a little OVD behind the lens. That's probably not necessary. At least he doesn't any longer do that unless you plan to go back and optic capture, which you would have to, my dream is that someday we would figure out how to do those cuts that Vasavida has shown for posterior polar and leave a plate behind and do it all at once. Do the posterior capsulorhexis along with the anterior capsulorhexis. And then you would leave that final plate until you put the OVD under that to move the hyaloid back and then place the lens. But you can see that it's very doable in here, and you can see the treatment zone, and you can see the OVD and the posterior posterior capsule and the IOL and the anterior hyaloid, and he's going to jigger around where the settings are so that he fools the machine into thinking this is a lens, and then he's quite able to do this in 72% of people with no other intervention other than redocking. And it's very interesting that this is what it looks like. All the cases look this way. This is the scrolled up edge of the posterior capsule. This is the posterior capsulotomy, and this is the anterior capsulotomy. And he says by day 1, that scrolled up PCC is always totally out of the way and you can't see it. So here is Vasavita, who I convinced to, the whole pediatric aphakia trial all involved trying to see if it was worthwhile to put in a lens in babies, but they all were doing anterior vitrectomies and then placing them in the bag. And they found that it was not better in the long run. It had more complications and interventions, but had they done it this way, that wouldn't be the case. And you can see with the LensX laser in this baby, he has made this perfect central opening. And he tells me at least that after doing 50 of them, and this was the economic barriers I discussed, about the model of having the femto in different places. I might have waited to mention that. And you do have to redock, so there is, the way it is today, so there is some small potential for increasing infection or losing your chamber, although that's been well taken care of by many centers around the world who redock for various reasons. I'm publishing with Boris Malyugin about really complex techniques where he's even placing a Malyugin ring in ectopic pupils or in ectopic lenses and then moving them with iris hooks into the right place to expose it for the femto laser, and then able to redock with the femto just cutting off the ends of the hooks part way, and he can still with OVD redock and hasn't had any complications to date. But there's always that added risk with the femto, not to mention the economic barriers. So I approached the menosis people who have now in 510K for anterior capsulotomy this device called the capsulotomy system, which will be something like $100 per case. And what it does is it goes in, and you'll see it in a moment with me doing a rabbit lab, and because it applies suction, it bends the capsule, and then a DC current, which is proprietary, breaks simultaneously everywhere in a split second the water molecules, and it actually ends up causing the edges to roll up, which incredibly causes it to be more stable than the standard implant, than the standard capsulorhexis. So these were great studies that were done by them in paired eye cadaver studies, and both femto. Interestingly, femto is the same as manual. It's different in every case because it depends on how old the cadaver is and so on. So that's why they were paired eye cadaver studies, and the femto and the manual turned out to be the same. So probably mainly the problem with the femto is the micro movement that we have, as we're doing our postage stamp as far as the safety of your anterior capsulorhexis. But the Zepto was way far stronger, probably because it rolls up on itself, and so you're presenting your pressure to a double edge, which is extremely smooth. So I said, well, can't we try this on the posterior capsule? And so in fact, we did complete a lab in Utah with Liliana Warner, Nick Mamalis doing the surgery. But this is my ex vivo rabbit study in the menosis lab. And you can see that the anterior capsulotomy is completed in a split second. And this has been done in humans now quite a bit, and it's in 510K. And you can see how intensely the trypan stains that edge. That's because it's rolled up and double. And now I'm using the blade to make an opening, and the rabbit has a very, very lax capsule. I wished I had had a capsular tension ring and so on. It was the hardest part was just making this opening. And the question becomes, well, we have to make this opening when we get our new technologies. We didn't have to with the femto, okay? But of course, and that is part of the learning curve. So here's OVD injected when I finally got that hole made into burger space, and you can see it kind of fill into itself. And unfortunately, in our lab in Utah, they just, the studies that were done afterwards, they just couldn't find a burger space. And right now, they're not sure the rabbit is a very good model for studying this. But I've spoken now with some veterinary ophthalmologists who says the rabbit has a very similar anatomy to humans, as do dogs with Weigert's ligament and a burger space. So that's all a work in progress. But now I'm putting the lens into the bag. I didn't do a bioptic capture, bicapsulotomy capture here. I'm doing just a standard buttonhole, and you can see how much stretch. I mean, it was smaller. The one they make for the rabbit is smaller and for at the moment, and you can see how much stretch it allows. And then I'm able to actually capture, and now I'm making the posterior capsulotomy. Okay, I'm putting this silicone ring, which has a nitinol wire in it, which is the way that the current is delivered. And you can see that it did end up, probably because of my angle, and they actually have a huge grant into NIH now to develop it better. It ended up being a little bit attached. It had one tag right here, which I was able to pull around, but I was able to make a true posterior capsulorhexis with it. And here I am. Before, it wasn't putting the lens in the bag. Sorry, I looked up. It was putting the device in the bag. But now I'm putting the lens in the bag, and you can see that I'll be able to capture it through that small posterior capsular opening. And really optic capture this in the manner that we hope to do in real life. And you can see that it stretched all that way. So here, courtesy of Richard Packard, is the capsule laser, another technique in development, which is fairly close to use for the anterior capsule, but this is a posterior capsulotomy. You can see already the anterior capsule, and this has a similar effect of the rolling up of the edge and presenting a nice edge, and it's a little machine that attaches under the microscope and makes these perfect capsulorhexes. So these may be the future, although I fear that people will forget how to do an anterior capsulorhexis manually, and that won't be good because we won't always perhaps be able to use these devices. So, advantages of SBCC. May I just finish, because I've got that 8:30 deadline, and then I'll happy to answer any questions. So I'm just racing to the end here. And disadvantages are the learning curve, obviously, but we have manual versus femto today. Tomorrow we may have Zepto, capsule laser, aperture CTC is another thing Mark Packer is working on. Lens exchange may require a pars plana anterior vitrectomy. But I don't know, I don't think light adjustable lens is going to be the thing. But if you don't know about the perfect lens and the concept of refractive index shaping, you need to get on the stick and learn about it, because this is one of the most exciting things on our horizon, which is a way of using a femto laser, a different proprietary, of course, femto laser, to refractive index shape any acrylic material so that we can change, we can add multifocal, take away multifocal, change, put in toricity, change the power, so we may never have to exchange a lens again if that happens. Elimination of fee for service, and that's a whole nother issue, which I'm hoping, I've presented a symposium for AAO where everybody in the world is interested in doing this with me, and I'm hoping to get Rand Paul to come and talk about the economics of this. Imagine the billions of dollars it would save on YAG capsulotomies, and I would hope that Medicare would pay us a lot more for the premium procedure of optic capture and less for YAG capsulotomies in order to drive things financially in that direction and save a lot of money. And imagine for the third world what it would mean to have one access to technology only and have cataract surgery be the final end of need of clearing your visual axis. So zero visual advantages, zero visual axis opacification, may eliminate bag lens subluxation if we actually do a bicapsulotomy, a bicapsule capture, and permits a toric lens use because it'll never ever rotate once you capture. You know, that's the perfect way to use a toric lens. It decreases dysphotopsia because we won't need a square edge, though there is no non-square edge lens available in the US today. And quieter eyes post-op because of lens protein being sequestered. It might decrease consecutive open-angle glaucoma, which is up to 15% after congenital cataract surgery. I believe, and Stegman believes, that's because we're releasing the vitreal elements to come plug up that tender little undeveloped trabecular meshwork. And you know, we know that we have a complication with pressure rises in glaucoma patients after we do a YAG and blow the anterior hyaloid. We know there's a higher risk of glaucoma after a complication of anterior vitrectomy. Why should this be the standard of care in children? And then possibly also, we stabilize the vitreous for life because we'll never have to break that hyaloid. And we have the most posterior position, or a little more stable posterior position of that lens, so that in high myopes this may reduce complications associated with vitreous syneresis, and particularly that are heightened by our doing YAG lasers on them, and space for secondary refractive piggyback, especially if we do the standard buttonhole. Then we could put another lens in the sulcus, opening the anterior capsule, and optic capture that lens, but that may not be necessary if we have refractive index shaping. But in babies, I'm not sure we want to buy capsulotomy capture only because of the need for a secondary lens. Then again, that might work too, because I'm not exactly sure where it's going to sit, in what plane anyway, and whether we'll be able to add a pure sulcus lens to that or open it. That remains to be seen. There really is improved vision with less stray light when you don't have a capsule compared to what we call a clear capsule, because it's never truly clear. And then the Summering's ring is confined to the equator, and possibly, if it stays stable, we might find that we actually have accommodation, and that's something I'm very interested in pursuing in the future. So all of these people have helped me in the development of this, and the ideas that came to it, and providing videos and giving good data, and I want to thank you very much for your attention. I think that we should look to, as soon as possible, and we have everything at our, there's no reason that we can't have a 30-gauge needle and a 3-piece lens and stop PCO today, tomorrow, when you go to the OR, except for that barrier of that learning curve, which is not really rocket science or monumental. And I'm looking forward to a new era of cataract surgery as a final visual rehabilitation. So I wrote about this at some length in iWorld. I haven't managed to. I'm hoping that Tom will have the time to publish that case that he did in JCRS. I tried to send a letter about it, but they said it was a telegraphic style and not detailed enough, but they had a 1,000-word limit on it, so you can't resubmit. I hope to have the energy to push this forward into the future, and I thank you for your attention. I'm happy to answer any questions.
Questions? Dr. Brooks?
Yes.
I'm good. I got it.
Oh, okay.
Well, actually,
Yeah. Go ahead. Somebody.
well, when you do the femto posterior capsulorhexis, and you showed a brief picture of that, how do you avoid the anterior hyaloid? I mean, if you haven't deepened that,
You have to be able to see it. So if you wanted to reliably do it in 100% of people, you would make your little opening in the posterior capsule, you would put your OVD through there to push it back, and now you'd definitely be able to do it, okay? But if you do nothing but standard flax, 72% of adults do have a real space that can be visualized by the catalyst, and the hyaloid remains intact when you do the posterior capsulotomy, according to Burkhart-Dick.
One, for the posterior rhexis, is there any role for capsular staining for the learning curve? And then second, for the capsular capture, do you have to modify the IOL power?
Okay, so with regard to IOL power, anytime you anterior capture, you can pretty well, unless you've got a 30 diopter lens or more, you can pretty well use the bag power when you just sulcus implant and anterior capture. Although if you ask Warren Hill, he'll say it can be up to maybe a half a diopter change as you get into the higher powers. Okay, it makes no difference in the lower powers. Menapace has actually published an entire chart of what you have to do when you buttonhole. Okay, and when you put it into Berger space, because your haptics are in the bag and the posterior capsule is so flexible, there's hardly any change till you get above 30, maybe a quarter of a diopter. I mean, we're talking really, really tiny changes from bag powers. Very good question. With regard to bicapsulotomy capture, I have no clue, but I'm assuming that it's going to be somewhere in between, which is no change, really. So that remains to be seen precisely. Now, if we could get 100% of people within a quarter of a diopter, that would really matter. And certainly if we have refractive index shaping, we can just fix that down to, incredible tolerances. With regard to Trypan Blue, as you know, Trypan is being used in pediatrics to make the capsule a little stiffer, or where there's a lot of elasticity to kind of stiffen it up. And there's some really good evidence now that it permanently changes the molecular structure of the bag. And so I always avoided that in children, because I'm okay using it in a hand motion eye, but in a baby that's going to be forever, we don't really know the long-term consequences of that. So and you have to use and it has to stay there for a while. The percentage that we're using that comes from DORC originally, or wherever it's coming from now, is a dilute percentage that if you just leave for a brief period of time will probably not make giant changes. Now, can you use this in the learning curve? People say that you can stain the posterior capsule, but if you polish it well enough, I don't know. I haven't found it really easy to stain the posterior capsule, and I haven't made a big effort to do it either, because it's just another step and I got to wash it out, and last thing you want is for it to go down into the vitreous. So there's no evidence that will cause permanent problems. It destroys your red reflex, and it's very hard to work with, when it flows around zonules and stuff. So I haven't really done it, but people say you can stain the internal posterior capsule. Of course, it stains basement membrane, so it kind of makes sense. But the cells that are on there seem to make it difficult, and doing the anterior capsulotomy, I mean, you can do it if you want in a child. He did that in that 8-year-old, as you see, but part of that was it was a hazy lens. I think it's most important when your visibility outweighs, the potential long-term danger of a molecular change. But if it's a matter of your learning curve, then I think it's well worth it if from now on you're going to be able to, keep people from needing YAG laser, 40% of your patients in the long run, if they live long enough. Yes?
You said you were going to talk to Senator Bull about reimbursements.
If I could ever get a hold of the guy, he's got emails that don't work, and I've had contacts with people that don't call back.
Negotiating the reimbursements, are you trying to get bicapsulotomy capture the same as a complex reimbursement?
I have no specific goal in mind. I want him to talk about the billions of dollars that are spent on YAG capsulotomies as a frequent complication, not to mention the morbidity that it leads to with the detachments and so on, and to think about it. In my mind, I don't know how much you'd be paid. I have no idea, and frankly, whether it'll stay a fee-for-service system is debatable to boot. Who knows what's going to happen? I'm no economist. I can't say what it is. That's why I want his advice. But the way I would imagine it is that they would pay you more to do it right the first time and permanently, and they would pay less for when you didn't do it right.
Well, that's using common sense, but that doesn't normally work when we're dealing with Medicare. So
yes, I wouldn't presume to say what's going to happen, if anything. Okay, and will the medical profession be magnanimous enough to say I'd rather have my patients have the best result and do what they would do for themselves than to want that added income? I mean, it's really tough, because medicine is working in this country in a socialized income and a capitalist outlay. I mean, our equipment costs more and more. Our employees expect a raise when they do a good job, and yet we're being, by legislative fiat, being ratcheted down more and more and more, and expected to take care of more patients who can't afford it, and it just is not sustainable. So I don't know what's going to happen.
The better we do, the faster we get, the more they slash our reimbursement. It doesn't seem that we get rewarded in any way of being more efficient.
Yes, and that's a whole other conversation that I'm neither expert at nor do I enjoy, honestly. And part of why I was happy to be ready to retire, which was a 30-year plan, that's the least reason, really, that we did. It was a plan all along to do that and just provide the care. We left a 22-doctor, multi-subspecialty with optometry and hearing and everything center, and where there was no care when we got there, and we're real proud of that. But it isn't sustainable, and who's going to fix it and how, I have no idea.
Maybe one last question.
Do you have a separate lecture on retirement planning?
My husband does, actually. Yes, he's actually the brilliant behind our building and retiring, and it's very interesting what we did. Yeah.
No, the other questions, there was one slide that touched on this, but Punkish and I and others in our department supported Ram Nagaraj. Do you know Nagaraj's work?
No, tell me.
Yeah, Nagaraj is a biochemist he was with us for many years. He's now at the University of Colorado. And he has a funded NIH grant on posterior capsular opacification.
Really?
And so he would like to take a different approach rather than an elegant surgical approach as you described, in terms of modifications of advanced glycation end products. And the TGF-beta, you had one slide related to that. So if you could modify TGF-beta and stimulation of fibrosis, maybe one element of capsular opacification may be related to these AGEs. And if you could squirt something in the eye.
Well, they've been squirting for a long, long time, and the worry that I have, well, I'll let you finish.
I think it would be helpful for you
I would love to
include
talk to
that
him.
in your talk. At least look up the literature, because there's quite a bit.
Would you
on
be
that.
kind enough to send me some, some
I just have
links?
it here.
Lovely. So if you'll send that to me, it's drlisa@arbisser.com, DRLISA. Another method. Well, I didn't go into, and we only had an hour, I didn't go into a lot of things in depth, but I don't know about that. But the problem that I have with it is we're modifying the function of cells that may turn out to be what keeps the bag attached and flexible and able to contain things. I mean, these cells have a purpose. They're constantly making something, right? And why do the zonules get loose and weak and have problems? So I would prefer, and there's no chance with our current technique of accommodation either. And so I would prefer to have an approach that does not mess with Mother Nature as much, personally. But of course, PCO is a giant problem, and so what might be the unintended consequences of that, I really don't know. But it's fascinating, and you're right, I should include that, and I will.
I think that would help provide some additional approach.
But I didn't add, the Anthony Maloof thing. I mean, squirting is not good enough. I mean, what he did, the way the capsula rexus, the menosis thing was thought of is he had that perfect pupil which sucked on it sucks over the capsula rexus, and then they were irrigating water in there. And if there were even a couple of cells that were sort of sequestered by a tiny bit of cortex that was left there, they multiplied all over the place. So even poisoning those cells, let alone changing their metabolic, ability, wasn't good enough.
Right.
So it remains to be seen. Thank you.